Are you still awake?
It's breakfast.
Am I sitting here?
Yeah, me.
Oh, somebody online hear me?
Yeah.
Yep, I got you.
I just checking to see if you're still awake, Dr. Isle.
I might have taken a little power nap here at the last few minutes.
Yeah, absolutely. We're gonna get started here in about a minute or so. Good morning, everybody online. Good morning, everybody. Appreciate y'all being here. I got 9 o'clock. We're gonna get started. Hey, Dr. Hayes, I'm gonna do a couple housekeeping things real quick before I cut to this, if you don't mind. Okay. So again, this is welcome to Union Hospital's December audit review. We have the very fortunate to have Dr. Eric Yazel, who's going to be he's the state EMS medical director, who's going to be doing your educational presentation. He worked at the University of Louisville last night, so I'm going to let him go first. So you can go to bed. I think he slept earlier, though. He's not fooling anybody. So anyway, things I want you to know on the screen as of 12:01 Saturday morning, the 13th, literally this Saturday morning, 12:01, Regional Hospital, Union Region. With that being said, the things that you see on the screen need to come here. Specific, any STEMI patients, they haven't been taking STEMI patients down there for a while anyway, so that's not a change. Everything, OB, postpartum, anything in pediatrics, it all comes here. That is going away down there as of that point in time. So if there's something at 12:10 in the morning, you need to bring it here, okay? That's important. So traumas, major traumas for sure, any long bone breaks or potential fractures, those kind of things need to come here. Any neuro injuries, those kind of things need to come here. We are a trauma center here. You're not going to be a trauma center there. That's not changing. Remember, if it's a significant trauma, it needs to come here. Okay. There's probably got, Jackie and I talked about it, and we just talked a little bit about advisory recap. I got a half a dozen people that are still alive because we are a trauma center, and they came here. We have trauma surgeons. We can have 6 trauma surgeons here in 10 minutes, even less than that, probably if necessary. So, things to keep in mind, just that needs to come here. But I wanted to tell everybody, remind them of that. Also, one other thing I want to remind everybody or let everybody know, starting in January, all audit reviews will be here. The second Tuesday of every month in this room. There might be one later in the year that I had to make the third Tuesday due to scheduling. I will let y'all know if that changes, but for the most part, we're here. All 12 are going to be down here now. Heather's going to help me quite a bit. Heather is the EMS coordinator for regional, going to be Union Regional now. So, and she's going to help me do all the audit reviews here. Okay, so that's going to be a big deal. So for all of you that like to present, we'll take any kind of educational presentation you like. Trent, we got you. You're good. So yeah, I can tell. Yeah. So anyway, so I'm gonna turn it over to Dr. Yazel. Dr. Yazel, I will do your slide presentation. I'll move it for you if that's okay with you.
Yeah, whatever works, man. Whatever is easiest for you.
I got it for you.
All right. Well, I was going to talk about some vascular emergencies, but first, a couple things I wanted to bring up too, and I think I'll double down on them at the end. But really, really important time in EMS in the state. Right now, we have a few things going on, but there's a lot of funding opportunities is the main issue. We have the Regional Trauma Commission breakdowns, the tracks, North, Central, and South. There's a ton of funding. I know you guys have had a presence on some of those, but I can't stress enough. It's important we have a seat at the table while some of this trauma funding gets out. And then along the lines of that, we have the Rural Health Transformation Act that's coming up in January of this year. And to make a long story short, I think a lot of you have heard of the One Big Beautiful Bill, but one of the things it's going to do is kind of disproportionately affect some of the rural areas of nationwide, not just our state. And in order to kind of plug some of the gaps in rural health care, they put a lot of funding together. And Indiana is actually going to have $1 billion with a B dollars to fill some gaps in healthcare over the next 5 years. And a lot of the initiatives the state has put together are EMS related. So really interesting time right now. 600 million of that 1 billion are going to what's called the regional coalition model. So they're breaking down the state into certain regions. Kind of initially talked about like preparedness regions. I've heard they're still kind of sorting out how the state's going to be carved up, but each region is going to apply for funding specific to your area. So if you say, hey, here are the major holes we have, we could use some, I don't know, high fidelity sim for maternal health or whatever that looks like, you can do that as a region, and there's a lot of funding available. As you can imagine, everybody's kind of scrambling to get their piece of the pie. So it's really, really important that EMS get to the table of those. And as these regional coalitions form, that we're involved out there advocating for EMS things, because as you know, there'll be other entities that come and try to scoop it up as well. But this really is something that should be a lot of it earmarked for EMS. So just an important time. I wanted to make sure I got my plug in for that, especially in case I got windy as we're getting into the talk. So. But yeah, mainly today I'm going to talk about some vascular emergencies and bleeding and things along those lines. I'm not going to bore you with a coagulation cascade or anything like that. As anybody who's heard me talk before, I'm not a super formal presenter. So by all means, feel free to interrupt me. We can go down rabbit holes, whatever you want to do. So please, I can't always see the chat or hear what's going on. So make sure to don't be afraid to interrupt me as we go through this. So. Got next one there for me, Barry. The one thing I always want to make sure is that we're thinking about how what our blood vessels look like in our body. And it starts off with the aorta, and I mean that's essentially a garden hose, is how I like to think of it as far as size and volume and things like that. Your aorta splits into your brachial artery or axillary and brachial arteries and your femoral arteries and things like that. Those are a slightly smaller, and then it kind of segues down into smaller ones as well. But the thing to think about is, depending on the size of the artery, this is how much time you have to stop the bleeding. And in your main arteries, the big ones, you have less than a minute. To be honest with you, I think I put less than 5 minutes. It's less than 1 minute. If you remember back a few years ago, and some of you young folks may not be old enough to remember, there was an NFL guy named Sean Taylor, and he was like an absolute physical specimen. I mean, just a freak of nature, healthiest man alive you'll ever see. And he actually was stabbed in a home invasion in the femoral artery, and he bled out. They're saying in about 2 minutes or less. So I mean, it doesn't have to. You can be the healthiest person on earth, and if you can't get that stopped, you don't have a lot of time. And in your aorta, it's even faster. And then as you get out farther to some of your middle-sized arteries, you got 5 to 10 minutes. Your secondary 30 to 60 minutes, and even your smaller like capillaries, or if any of you guys have seen like a varicose vein that'll bleed, or a small little artery, you can go for longer with that. But you need to start thinking about when you see bleeding, knowing what vessel might be close and thinking about how fast that bleeding might be going and how quickly a patient might exsanguinate. So, next slide. And then also think about what happens there. And I don't want to get into a bunch of metabolic stuff. I'm barely awake myself, and I'll certainly put all you to sleep. But think about how what happens with your blood loss. Not only are you losing volume, but your body responds by the kind of fight or flight. So you get a lot of epinephrine, vasopressin, some of your stress hormones that signal your body's arteries to clamp down, and that'll increase volume as well. And then you see a compensatory increase in heart rate as well. So, there are some physiologic things that are happening that are important, that are aside from just your standard loss of volume there. Remember, there's an excess of epinephrine and other things. And then there's other things that happen, as you do some of those things, your epinephrine, we all know that lately we've started to see more and more studies that show it may not be the optimal medicine to give during our medical arrest. Well, even that epinephrine that we see during bleeding can cause problems. It increases oxygen demand. So it causes loss of oxygen in your tissues, decreased perfusion to your kidney, your liver, your gut, brain, things like that. It's trying to shunt blood into the system, and it kind of clamps down in other parts of the body. So that's why I put that part of everything has a price. I mean, epi does a lot of good things during a bleeding episode, but there are some side effects of that as well, and that's what you see when some of the damage that can occur from hemorrhagic shock. One thing I think is a nice, easy way that we can take a quick look and understand the stress that's happening on the body during an arterial bleed is using end-tidal CO2. And I know that's not something that we normally think of, right? You don't normally say, oh, we've got a bad trauma, they're bleeding a lot, we better stick an end-tidal on them right away. But if you actually watch the data on that, that is a great indicator of tissue hypoxia, things like that, lack of blood delivery of nutrients and things along those lines. And they've actually done some studies that show this. If you go to a trauma center and watch them resuscitate a patient, a lot of times they look at what's called a base excess, and that's a blood test that basically is a guide to show how much resuscitation the patient needs. So if you see a base excess of -10, -12, that patient needs blood and they need it fast. Well, they found that an end-tidal less than 20 in a trauma patient who's actively bleeding correlates very well with a base excess of -4 or worse. So again, if you've got a bleeding trauma patient, they have a low end-tidal, 10, 15, something like that, that they're getting low on resuscitation. And if you have blood products, you need that. If not, you need to be hustling somewhere that does have them. And it actually correlates with, and I'm sorry, I usually do this on Canva, but when it switches over to PowerPoint, sometimes my formatting gets all squirrely. But they did a study on the different stages of shock, right? I think a lot of you, when you went through your EMT and medic schools, they talked about the stages of shock, right? Well, if you have a trauma patient with an end-tidal greater than 35, you can reasonably assume they're in stage 1 or better of shock. If it's less than 30, then you start thinking about they're in stage 2 or 3, and less than 22, pretty much reliable that they're in stage 4. And if they're less than 18, it is 99% specific that they're in hemorrhagic shock. So again, a quick, easy way that you can actually get an estimated blood loss, right? Because stage 1 tends to be 15% or less blood volume loss. 2 and 3 starts to get up to 15 to 30%, and when you get into stage 4, you're talking about 30, 40, 50% blood loss there. So your end-tidal is a quick way to kind of get a feel for that. That QR code actually goes to this study that kind of talks about those different levels and how to interpret it and things like that, if anybody wants to take a deeper dive.
Sorry about the formatting. I tried to change it the best I could. So.
Oh, you're good, buddy. No, it does this all the time. It's usually real minor and stuff. So. But yeah, so what we talk about is, think about where the bleeding's at, use your end-tidal to guide you. But at the end of the day, the question is, what are you going to do about it? What kind of tools do you have, and how should you respond? And, the one thing, and we just kind of talked about this last hour, number one is you're on the clock, right? At the end of the day, a lot of these vascular things or these arterial bleeding, you can temporize it with, different things, but at the end of the day, they need to be in an OR, getting repaired for whatever insult happened to that blood vessel or what part of their body. So, your goals, again, it's a bizarro world where, in a medical arrest or a sick medical patient, a lot of times we stay on scene. We use the modalities that we have to try to stabilize them. Then when they're stable, we transport. In some of these traumatic injuries, arterial bleeds or other things, there's nothing that's going to stop them. And the longer you wait, the sicker patient you're bringing to a trauma center. And the whole goal that we have in pre-hospital is to try to buy these trauma surgeons as much time as possible so they can get in there and fix what they need to fix. And the better we resuscitate those patients, the more time they'll have. And even small wins, providing them another minute or two can make the difference between life or death. So always be cognizant of that when you're running on your trauma patients that are bleeding. And again, this is one where if you got to go, you got to go. So think about where you're going. Think about your destination decisions. I know there's just some talk about, some of the changes in your area, destination choices and things like that. So wherever you're practicing, make sure you understand, if you are, if you're resuscitating a patient and you're going to, and you have a 10-minute drive to a small critical access place and a 20-minute drive, to a comprehensive trauma center, make sure that you take longer and go to that trauma center. Smaller places sometimes have trouble mobilizing blood in a rapid manner and things like that. And really, it's going to be more of a pit stop. And so a lot of times you're losing time. And I always think this is one of the toughest decisions that we in EMS have to make on a daily basis is, okay, facility A has less capacity, but it's closer. Facility B can do more, but it's a longer drive. Where's that tipping point where you say, no, that's too far. We got to stay local, or yeah, I think I can make it there. That's a really challenging decision. And one of the things when I talk about, I know you mentioned run sheets and things like that. That's one thing we're working on at the state level is to try to improve our data so we can help you make evidence-based decisions. So we say, hey, this patient, this subset of patients went to facility A, here was their outcome. Maybe we're over or underutilizing our local hospital. Are we taking patients there that are too sick? Are we taking too many Are we bypassing them too much and taking patients to a comprehensive center that discharges them a couple hours later because they weren't that sick? Those are the kind of decisions we're going to try to help you make as you navigate this with some improved data. So the number one fundamental of bleeding control, direct pressure, right? And it's a lot of pressure. Don't be tentative with this. You got to push. You got to push hard. And I mean, if it's to the point where you're, especially a large vessel, do not let go. Period. Someone else can work on the patient around you. You just hold pressure. I've had times at our trauma center in Louisville where literally I remember about a year ago, I went all the way up to the OR with my hand wrapped around a subclavian artery in a gunshot wound because there was no other way to get it stopped, and it was bleeding so fast that even if I let go for a few seconds, I felt like we might lose the patient to exsanguination. So a lot of pressure and steady pressure, and don't let up. Also, don't forget about just keeping it above the heart. Do everything you can, in addition to direct pressure to help your cause. So, again, getting that extremity or leg elevated if you can. Junctional things can be hard to stop bleeding, things in your groin, armpits, things like that. So start learning your different pressure points. Sometimes you can, while you're holding direct pressure, someone else can hold pressure on an area kind of upstream on that artery where it may come closer to the surface. Like if you're pushing, in the femoral, pushing hard on the femoral artery when there's a bleeding vessel, a few inches below, things like that. So make sure you're using every tool that you can to slow down the bleeding. And then have your tourniquets, right? Everybody should be carrying these. I don't know if it's still an issue, but for a long time, there were a lot of knockoff cat tourniquets on the market. I think that were made, I think it's made in China, and they weren't holding up as well. So make sure that you have examined all make sure you've examined all your tourniquets. And I always say carry two of them. One that you can practice with, like if you've got some downtime, and then the other one that you'd actually use when the scenario comes. And make sure that tourniquet is set up to where it's able to be used rapidly. Because a lot of times, this is going to happen when it's completely unexpected. The last time I used my tourniquet, I had a guy whose dialysis access ruptured, and he was literally hitting the bed we have curtain beds back then, and he was hitting the bed 2 beds down from him through the curtain. He was bleeding that briskly. Had to have somebody run out to my truck and grab a tourniquet. Thankfully, it was there, accessible, and ready to deploy. So always carry two, have one that you can practice with because they will get weaker over time. The Velcro will break down, the winch strap will get loose, things like that. So have one that your practice tourniquet and one your when the shit hits the fan tourniquet. That's what I say. So one thing I like to do too, this is what we do with our tactical guys, is very rarely are you applying a tourniquet in like a nice, chill, calm, controlled manner. Usually if you're throwing a tourniquet on, somebody's hurt, somebody's bleeding, and somebody's bleeding badly. And it is hard not to get flustered or stay calm and smooth with your tourniquet applications when blood is squirting up and into your face, or you see a fountain of blood shooting across the room, things like that. There's usually a lot of noise, it's chaotic scenes and things like that. One of the things I've always thought is interesting when we train our tactical guys, we will actually have them come in, apply a tourniquet to a patient and time them. And then we'll do the same thing. We call it sensory overload, where we do the exact same scenario. Everything's exactly the same, except as soon as they come in the room, we have two or three guys screaming in their ear the entire time. We actually squirt them in the face with a squirt gun, and we'll throw some firecrackers in a trash can, which probably isn't great from a fire prevention side of things, but it's loud as hell right next to them. So you've got things blasting next to them. You're squirting, people are yelling, and you will be surprised. A lot of these guys are seasoned veterans. A lot of them done military service. So this isn't a foreign thing to them, and their time of application of tourniquet will almost double pretty reliably. So, again, make sure you try to practice with as realistic environment as possible. Not saying that you need to put a black cat under somebody while they're trying to put a tourniquet on, but practice in those environments with a lot of stress, a lot of distractions, things like that. I think that's important as you work on your tourniquet applications. I think it's interesting because for the longest time, tourniquets were pretty standard, ubiquitous everywhere. And then they kind of fell out of favor 10, 15 years ago for a while. We didn't see near as many. And then there are some new studies that showed that they were safe, that you didn't have to worry about the nerve and vascular injuries as much as we originally thought. And essentially, if you could pretty much guarantee that tourniquet was going to be on 4 hours or less, there wasn't much to worry about. Well, in the interim, there's been a few studies that show that may not be accurate. And I'm not advocating for decreased tourniquet use, but I do advocate for thinking about your tourniquets. Do they really need one? And if they do, making sure that you're keeping on for the minimum as possible. And I still subscribe to the adage of once you put it on, it stays on until you get to your definitive care facility. But I will say there is some EMS literature and some other medical directors that are different philosophy. In fact, West Virginia they're a state protocol state, and they just came out with a protocol on tourniquet conversion. So actually taking down some tourniquets. Now, I will say West Virginia has some pretty austere environments where, they're transporting somebody from a trail on a mountainside, 45-minute, hour, kind of transports. I'm not saying that's, doesn't happen in Indiana as well, but it's with a lot less frequencies. Not advocating for a takedown protocol, but it is just something to think about and make sure you're aware of your time. There were some studies that did show that some of the vascular injury and permanent disability from tourniquet applications may happen more often than we originally thought, is some of the driving force behind this. So not advocating for any changes, but just something to be aware of there. So I'll hold for a second. Any questions or anything like that? All right. This is one of my favorite things because it's super easy and it actually works really well. When you have an arterial bleed, especially like my favorite is, I'm sure some of you have run on these where somebody gets their access taken, they get unhooked from dialysis basically, and they have a persistent arterial bleed. It's usually, a relatively small bleed, but they're ornery. They won't stop. And, you'll see somebody who's got a little just pinpoint bleed, but I mean, it's pumping and pumping and, shooting, 18, 24 inches in the air. This is something that we all have readily available. You take the lid off of a Diet Coke, Mountain Dew, whatever your drink of choice is. You put that plastic cap over top of where that pumping bleed is, and then you wrap it in Coban. Simple as can be. You can apply it in about 2 seconds flat, and if you wrap that Coban nice and tight, you'll find out a lot of times when you take it down 30, 60 minutes later, there's a dime-sized clot there, and your bleeder is stopped. So that's a nice, easy way to stop bleeding. Wouldn't necessarily have to put a tourniquet on. You can apply this, and then if it's still leaking around the bottle cap or something like that, you can apply a tourniquet. But it's just a quick, nice, easy way to stop bleeding. Varicose veins that'll take every once in a while. Somebody will have a varicose vein that tears or something like that. You get a pretty brisk bleed. These are great for those as well. Like I said, quick, easy, nothing to it, and it works really well. One other thing I use sometimes is actually, I think some of you have probably seen these bottles of lidocaine or any kind of medical bottle, those plastic caps on the top of them. I love those too. What I'll actually do is I'll throw one little stitch in and I'll run the strings of the stitch through a hole. I'll make a hole in the top of the that little plastic bottle cap, and I'll run those strings through it and then cinch it down. And that little plastic cap will actually apply some pressure right to the bleeding site. The other thing you can do is the same thing. If you have like one little stitch in the skin, you can run those strings up through a three-way stopcock and cinch that stopcock down. That one's kind of nice because you can gradually loosen it to see if your bleeding is going to hold after a clot's formed, which is kind of nice too. So those are little quick tricks that you may not have that availability on a truck, but if you're there in somewhere where you're trying to help somebody get that stop, that's an idea you can throw out there, and I've had good success with it too. So. You hardly could get a talk with me without me working in whole blood somewhere. And this is the end all be all for me at least on bleeding resuscitation. At the end of the day, you're losing blood, makes sense to put blood back in, right? And I always say whole blood, but any sort of blood product is wonderful. And so there are studies that show whole blood is kind of the gold standard, that you have the most clotting with the least volume. But you can do what you call component therapy. If you can't get a hold of whole blood, which is a major challenge for a lot of our trauma centers. Even at U of L, when I'm working at a level 1, we have a pretty limited supply of whole blood. So you may have better luck getting packed red cells or FFP or something along those lines. There's still help there. You still get clotting factors, you still get oxygen delivery capacity and things like that. I think a lot of places, when they look at developing a blood program, they try to get whole blood, and then if they run into a roadblock, they just kind of stop. And just down my way, Scott County EMS carries packed red blood cells, and they've had some excellent, excellent saves that I've seen firsthand. They had a stabbing on a day when there was nobody flying. They had about a 40-minute transport time. Patient started with tachycardic in the 150s, blood pressure in the 60s, and the patient was stable as could be upon arrival at the trauma center after getting a couple units of packed red cells on the way. I had a postpartum hemorrhage. Same thing. I mean, she looked pale as a ghost. She was sick by the time she got to me. And I think if she hadn't been able to get blood en route, same thing. She may not have made it down to our ER. So big advocate for that. Just makes sense. I think a lot of times back in the day when we would really resuscitate aggressively with fluids, we get a little false sense of security, right? And say, okay, yeah, their pressure is 60. We blasted a few liters of fluid and got it up to 100 systolic. All you really did is dilute what blood they did have in their body further. And, now with some of the permissive hypotension philosophies and things like that, may have, not to say did more harm than good, but it certainly doesn't replace blood products in the resuscitation pathways. We are getting more and more services in Indiana that are doing it. What is that? I'll count out. What are we up to, 10 now? Do we hit double figures? Yeah, 10 services doing it, spread throughout the state. So just a quick plug, there is a Indiana Blood Coalition where all the different services get together. services that are interested and talk about their protocols, their equipment, their training, things like that. So if you are interested in a blood program, understand that you don't have to reinvent the wheel. One of the cool things is a lot of these 10, they all have slightly different setups. South Bend, for example, they're near a trauma center. As the way I understand it, I think they check out a unit of blood each day and kind of have it out in the community, and then bring it back. Whereas like Crawfordsville, their model is they have a unit of blood that they purchase. They keep it for 14 days. The shelf life's 21 days. So what they do at the end of 14 days is they drive it to St. Vincent's, the trauma center in Indianapolis, and it becomes their priority unit number one for that last 7 days. And any trauma center is going to go through that unit. So they're not wasting any blood. It helps them from a financial standpoint. So that's kind of a nice model too. And each one of these programs has a slightly different setup. So I think it's a really good meeting to get on if you're interested, because you can hear those different things and figure out which one works best for your service and your community.
Hey, Dr. Yazel, so if Crawfordsville takes that to, or whoever takes it to a level 1 trauma center or whatever, do they just exchange it for another?
No, so what they do actually is they'll buy it for, I think it's like 700, $800. They sell it to St. Vincent for like 400. So they're not, they're getting some return on investment. And then when they get back home, essentially, they're getting their new unit delivered to them from their third party vendor is the
All
way
right, I was just curious. I wasn't sure. All right.
Yeah. Yep. The interesting question that we're struggling with, I shouldn't say struggling with, but thinking about at the state level is eventually there's going to be a kind of a ceiling on these blood programs, right? I mean, when we talk about blood supply and how much we have to watch that, does Indiana have a blood supply for 50 programs? We're at 10 right now. Can we support 50? Maybe, probably not. I think once we get to about 30, we're really going to have to look at our supply. We definitely can't get up to 100. And, as we're developing our network, we really need to be aware of that and, what our ceiling is as a state, and make sure that our blood units are deployed to benefit the most of the population, right? I always say, we don't need like a single county to have 5 programs in their county and then, a third of the state have no coverage, right? So we need to think about our resource allocation and things like that. One thing that the programs in our state have been really cool about doing is sharing with other services adjacent to them. Almost all of them have cooperative agreements with local services where if they're in need, they'll meet up with them, do some sort of handoff and things like that. There's still, and that's another good discussion that happens at the Whole Blood Coalition on what that looks like from a regulatory and billing standpoint and things like that. So just something to think about as we grow as a state and these blood programs start to take off, is just strategically deploying our units to benefit the most population. And there's all sorts of. One of the things I think might be a game changer is there's freeze dried plasma that's being used in the military and things like that. That would increase people's shelf life markedly. It can go up to a year. So in that scenario, that makes it a lot logistically easier. We're also looking at drone delivery, all sorts of fancy models of getting blood product out there. The other thing we've looked at doing is having blood rendezvous points. Rwanda is a country that's been war torn for a long time, and they don't have a lot of great hospital infrastructure. But what they do have is they've done that. They have essentially blood outposts where along major traffic arteries, every service will know that if they go to mile 22 on this road, that there is a blood rendezvous point that they can pick up a unit of blood on the way to their destination facility. That's something that we've really looked at pretty hard in Indiana is, okay, does it make sense to look, and say, okay, for Terre Haute, do we put something, on 70, 15 miles out from town so that an outlying service can come in there, pick up a unit of blood on their way in, or, what does that look like as far as a setup goes, or say, a local service carries it. Another adjacent service could say, okay, let's rendezvous at this, pre-agreed upon point on 41 or, some things like that to make sure that blood product's going farther and that we're able to kind of get blood going upstream so that we're delivering as stable a patient as possible to our trauma centers. One of the things, TXA, I don't know, are you guys using TXA in your protocols around where you are?
Yes.
Yeah, say a lot of places. A lot of places are. There's a study, Crash 2, that talks about use of TXA. There's the QR code. It's been studied a lot in different things: intracranial hemorrhages, nosebleeds, vaginal bleeding, a lot of different kind of bleeding. Some of the results, honestly, are kind of mixed. I'm still a big advocate for it. I think it works in certain scenarios. Honestly, it's relatively inexpensive, and honestly, a relatively safe medicine as well. One of the things I always tell people if they're interested in a whole blood program, the first thing you need to do is figure out how often you would need blood or use blood. And the best way to do that is say, okay, how many patients in the last 5 years have qualified for our TXA protocol? Because a lot of the patients that are going to qualify for TXA are the same ones you're going to want to give blood products to as well. So I do advocate for, even once you do have blood, to still keep TXA up front and foremost in your thoughts and give it to your sick patients as well. I get asked a lot about calcium as well. Some places that are giving blood products and TXA, kind of that third leg of that is calcium as well. Most of the studies, I guess I should say most of the studies, it hasn't been overly well studied. Basically, what happens in a patient who needs mass transfusion, so multiple units of blood, they eventually get hypocalcemic, which can have some negative effects on clotting and acidosis and other things down the road. So some places are saying, okay, if they're sick enough, we need to give them blood. We want to go ahead and get that calcium on board early. That makes sense to me. I don't have any issue with that, and I think that's a nice protocol addition. Some places who don't have blood are going ahead and getting calcium on board upstream in a patient that they're anticipating might need a mass transfusion. I don't know that you have the data to do that yet. So I haven't been doing that with my services. But if somebody does and decides that's the path, I certainly don't have a lot of argument with that as either. The one thing I will say is you need to be, I guess, respectful of the calcium, as far as it can be a dangerous medication if it extravasates. So if you have an IV that blows and that calcium gets in the sub-Q, it can be a bad deal. And especially calcium chloride, which is what we use in EMS a lot, right? Because that's our code drug formulation of calcium. That's the one that's the most dangerous. So if you're going to do these protocols, I would think hard about adding calcium gluconate instead. That's one that's a little safer. The negative is you have to give it about 3-to-1 as far as volume versus calcium chloride. It takes a lot more calcium gluconate to get to that appropriate calcium level, and you have to give it a little slower, but it's a much safer formulation. So, I guess the one main word of caution I would say is if you're going to do calcium chloride as a protocol, make sure you've got a good IV that you trust. Is probably the take-home point there. This is actually the problem if you give calcium and extravasates. I mean, this can get real nasty. I'm actually an expert witness in a case coming up on a calcium extravasation lawsuit that happened in an ER. So, I mean, this is a real thing. I think some of these things we try, you say, oh, you got to worry about this. And people are like, I've never seen that happen. Don't have to worry about it. This is a big deal. So, if you've got a real tenuous 22 gauge in somebody's thumb, this is not the medicine to give in this scenario. If you've got a nice 18 gauge and AC, feel good about it, it's flushing well, fine, go for it. But just be cognizant and treat it with some respect. Dialysis. This is a big one where we see bleeding, right? It can be a lot of different things. But the most common we see is where somebody sat in dialysis, they remove them from the machine, and the bleeding won't stop. And there's a lot of different kinds of dialysis bleeding and management. That's a QR code to an article that goes a little more in depth on some of the dialysis complications and things like that. The one thing I think people don't understand is, yes, there's some weird vessel things, from fistulas and shunts and things like that, that are more prone to bleeding. Obviously 3 days a week, they're getting some sort of stick of an access, so you're going to get some bleeding complications. What makes it even more challenging is essentially, without getting too deep in chemistry, dialysis patients' platelets don't work right. And so the higher someone, the more someone needs dialysis, the worse those platelets are going to function. That graph on the right there is talking about how normal platelets aggregate, which is what forms a clot. You see that percent aggregation is almost half less in somebody who's uremic, which means you have a lot of the dialysis toxins build up and things like that. So not only are they more prone to bleed, they're much harder to stop bleeding because of this platelet dysfunction. So always be aware of that. There's a lot of different kinds of access, and it's really important to know the difference. So, a lot of you guys have probably felt a fistula where you kind of put your hand on it, that you can feel what's called a thrill. You can feel that vibration from that. That's where they've connected an artery and a vein together. The vein isn't used to that high pressure of an artery, so it dilates big, which makes it a great thing to access and makes it real easy to get them hooked up for dialysis. Sometimes, essentially, they have a Shiley catheter, which is basically a central line that they can do dialysis for. Some people have grafts, which is like a synthetic connection between an artery and vein that they can dialyze through. You get some infection issues and other things from a graft sometimes. The fistulas can be a problem because, as you can imagine, when you hook up an artery and a vein, and that vein that's hooked up gets bigger and bigger and dilates, sometimes it can do that too much and it can rupture. And when you're sticking it 3 days a week for weeks and months on end, that becomes a risk. So if you're picking someone up and they're able to tell you what kind of access they have, that should be your absolute first question. If you walk in the door and somebody's bleeding from dialysis access, you should say, "What is your access? Is it a graft, a fistula, a shunt? What is it?" The other thing that happens sometimes is some of these people who have the Shileys, the central lines, the one that's there on the bottom left, those will get dislodged. And those are deeper down in the chest, a lot of times up in the kind of the subclavian. So you'll see it up around their upper parts of their pecs. That's in an area you can't get to and compress. You can't tourniquet a vessel deep in somebody's chest. So they will just bleed and bleed and bleed sometimes. So that's an important one to know too. So again, your very first question should be, when there's an issue of bleeding in a dialysis patient, what is their actual access point? So, what do you do for it? It's honestly some of the same fundamentals that you do for anything else. Standard hemorrhage control. You want to do some direct pressure. You can try the bottle cap thing I spoke about. Tourniquets. Last one I had, I put a tourniquet on, and then I had to put another one above that one because it was bleeding so briskly. One frustration I have is this is one that unfortunately sometimes we get armchair quarterbacks because they're like, "Oh, don't do that. You might ruin their access." And I have all the respect in the world for dialysis access. They have to be, preserved as best you can, because it is hard to maintain good quality access. But at the end of the day, it's better to have a live patient who needs a new access than it is a dead patient who has a nice looking shunt, right? So sometimes you got to do what you got to do. The other thing is, if they're bleeding and bleeding briskly, this is another one that you need to think about your destination decision. This is something that, you may need a facility that has vascular surgery capability. Obviously, with dialysis access, it's got to be a place that can do dialysis. So again, understand where you're going, because, when you stop at a place that doesn't have any of those, there's really not much more they can do besides what we're talking about here, right? They can put a tourniquet on, they can hold pressure just like you can. Do they have a vascular surgeon that can take him up to the OR and tie it off? No. So if what you're doing doesn't work, there's nothing magical that, some of the more rural critical access facilities are going to be able to do to help the patient either. So. AAA. I used I was like, sometimes I put these pictures in there and I forget what I was trying to talk about. But, so you got your dialysis access. The next one that I think about is your abdominal aortic aneurysms, triple A's, as we call them. These can be really scary and really problematic. And basically what it is over time, due to weakness of a vascular wall, prolonged high blood pressure, things like that, that blood vessel will dilate. And as we talked about, the aorta is essentially a big garden hose. So the more that dilates, the more stress it puts on the wall, and eventually it gets to a point where it's at risk of rupturing. And in that scenario, someone can get very unstable very quickly. So if you have something, the first, you want to ask a few questions because number one, a lot of people are walking around every day with abdominal aortic aneurysms. They're followed by vascular surgery. Kind of the general rule of thumb is anything less than or anything bigger than 5 centimeters, they start thinking about fixing it. So when when you feel it, or when you get a history that somebody has belly pain and they have a known aneurysm, the questions you need to ask is number one, have they seen someone for it? So that tells you if they have, that tells you that it's been there for a while, that someone's monitoring it and things like that. The next question is, how big is it? Is it 3 centimeters? You're not as worried. Was it 5 centimeters at last measurement? They've been talking about making some plans for the OR. And that's a big deal because that could be a sign of imminent rupture if they're in pain. And how long has it been since they measured it? I'll have somebody tell me, oh, it was only 4 centimeters. And then I'll ask them when the last time they measured it, and they'll say 2008. That doesn't tell you anything. You can reasonably assume that it's probably grown to critical size in that interim. So, and then what are they planning to do? Are they planning to fix it? Are they just monitoring it? Where are they at? So if someone tells you that they are, making some OR arrangements, they're supposed to get scheduled for surgery down the road and things, that already tells you that it's probably reached repair size. They don't like to repair these if they don't have to, because honestly, it's a complex surgery and there's a reasonably high mortality, even just with a routine repair. When you're talking about after it ruptures, if you can get somebody up to the OR, it's almost a coin flip on if they're going to survive that procedure or not. So that's why this is a big deal. One thing to remember is a lot of people are going to have one of these. So you may feel one, and just because you can feel it doesn't mean there's an impending rupture. I had one where, unfortunately, the patient was at a Golden Corral and their belly started hurting them. And a crew went out, they felt an aneurysm, and they called a helicopter because they're about 30 minutes away from a vascular center that could take the patient. And when they arrived, the patient actually just had been chowing down at the chocolate fountain there at Golden Corral, and they knew about they'd had a AAA for years. And so the patient got a $40,000 helicopter ride for some bubble guts from Golden Corral. So understand that sometimes people will be living with those every day. Now, that being said, if somebody has a known one and they have a sudden increase in pain at that site, that certainly can be a sign of impending rupture. And so, yeah, sometimes you have to err on the side of caution. And again, it's real easy to armchair quarterback somebody, but just be aware that some of these are very stable and have been there for a long time also. They don't always present as straightforward as you might think. The last one I had, I remember I walked out of the room and I said, that guy looks miserable. Either he has a kidney stone or he's rupturing a AAA, because he was kind of writhing around like a kidney stone does. His pain was in his flank, because a lot of times that's where the aorta sits, kind of on the psoas muscle and retroperitoneally. You'll feel that pain. So he looked exactly like a kidney stone. And then sure enough, got the call as soon as he went over to CT. Sometimes your elderly patients, that'll be the cause of a syncopal episode. So all of a sudden they pass out. You don't get any history of belly pain or anything like that. Say they pass out and go unresponsive. You'll have no idea. So anytime you see syncope in an older person, someone, I'm 50 this year, so I guess I'm in that range. Anybody 50 or older and unexplained syncope, got to start thinking about AAA. It's kind of like with the younger female. If you have unexplained syncope, you always got to think about an ectopic. Syncope in an older patient, always think AAA. Unexplained hypotension, again, that's bleeding from an aneurysm or just if you have somebody who's in cardiac arrest and really don't have any, any known trigger for that, you're not going to be able to diagnose that real easily in the pre-hospital setting, but always think about a ruptured AAA as a potential cause of unexplained arrest. Again, if you have a patient who suddenly has some, tearing abdominal pain and then goes unresponsive, that would certainly point me to the direction of a ruptured aneurysm. As we see pre-hospital ultrasound kind of become more and more common, those are things that we could start evaluating for in the field. But I think we're a ways away from those kind of protocols right now. Any other questions right now?
Doesn't look like it, sir.
All right. This is another one, especially if you're out, I just was griping about using Air Medical, but I mean, if they're sick, you don't have much time. They're going to die within the hour if they have ruptured. And this is one where they put these cases on our oral boards a lot. And you're one of the things that's a critical step is that you type and cross them for 8, 10, 12 units of blood. I mean, you've got to get to a place that has a capacity for a massive transfusion. And you're going to need vascular surgeon. These are ones you can't get too good of access in. You want 2 good large bore peripheral IVs. And then if you are a service that's carrying products, get those blood products in ASAP because you just don't have much time. The chest version of the AAA is the aortic dissection. And kind of the classic thing for this is what they call a wide mediastinum. This one's tough in that, again, this is one that's not going to be easily diagnosed in the pre-hospital setting. I mean, kind of the classic thing that you would, that would show up on some of your tests and things, and sometimes seen in the real world is just a blood pressure discrepancy. If you take a blood pressure in the right arm and left arm, if someone has chest pain and looks to be in distress and restless, and they describe their pain as tearing and radiating to their back, those are things that make me start wondering about a dissection as well. And the big thing with those are, in this day and age when we're always looking to shave time on our acute MIs, get them to the cath lab faster, 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 it's real easy to get sped up and not evaluate for a thoracic aneurysm. And they get over to the cath lab. What happens when they get to the cath lab? They get a bunch of blood thinners and things like that. And if they're, dissecting in their thoracic aorta, and already starting to bleed, that can be fatal. For some of you older folks, that's how John Ritter, the Three's Company guy, passed away. He had what looked like an acute MI and went to the cath lab, got some blood thinners, and it was fatal for him. The EKG a lot of times will resemble an acute MI because the dissection of the blood vessel will cut off the blood supply to the coronary arteries. So they will essentially have ischemia of their coronary arteries in an MI, but it's actually from a dissection, not from a blockage. There's different kinds of dissections. Not all of them are operative. In fact, a lot of them aren't. If it's just the top of the arch, then a lot of times those are fixed surgically, but a lot of them extend through the arch all the way down through the aorta. And a lot of times in those scenarios, especially if they haven't ruptured, those either are non-surgical and the treatment is blood pressure control, or they put some sort of graft or something like that in. The key is blood pressure control. And I say, don't get me wrong. A lot of times, they'll present with chest pain, in your protocols, you're given nitro. I think that's okay. But in a recognized dissection or a high suspicion, that's not the one of choice, just because it's not a controlled lowering of blood pressure. We've all seen when we give nitroglycerin, some people will go from 150 down to 80, and then also sometimes you get some heart rate effects from it as well. So labetalol is a great medicine in these scenarios, but a lot of times it's just going to be getting them to a destination facility where there's a lot more different choices on blood pressure medications, that could be given that'll help kind of stably lower that blood pressure. Again, as we look at ultrasound, there's going to be some some increased applications for that. All these vascular things I'm talking about, a lot of times ultrasound can be helpful there. And we're seeing more and more places carry them. I do think we need to ramp up our ability to train for EMS specific indications, as well as help QA those images. You can ultrasound people all day, but if nobody's going through them, giving you pointers on how to get better ultrasound windows, how to interpret those results, then it's not a tool that's reaching its potential. So hopefully we can continue to see that expand, because I do think that'll be a game changer for some of our things.
Sure.
Last one I'll talk about, and probably the scariest of all of them. I don't know if any of you guys had a carotid blowout before. Anybody in the room?
No, I
They're
have not.
probably the sickest patients I've ever seen. I've seen maybe 4 in my 20-year career. But if you get somebody, it's a lot of most of kind of the classic scenario is a patient who's had some sort of head and neck cancer. So like throat cancer or something like that, where they've gotten radiation to their neck and they've had some sort of surgical procedure where they've done like a radical neck dissection to try to remove some of the cancer there. Then a lot of the tissue over the carotid artery will get weak with time, and that carotid will become much closer to the surface. And it's a very high pressure artery in our body, and every once in a while, in those scenarios, that skin over top of it that's protecting it will get so thin and friable, and eventually it'll rupture. And if you can imagine, a carotid artery at the surface rupturing, this is a lot of blood, and a lot of blood that happens fast. So this is another one where you don't have any time hardly to stabilize this patient. And and again, where are you going to tourniquet that, right? You can't put a tourniquet around their neck, you're kind of stuck. So this is a real challenge to manage. And but it's not as rare as you might think. 3 to 4% incidence in patients who have had major surgeries can be up to 20% of people who've had radical neck dissections if they got radiation previously. I put it kind of, sometimes in those scenarios, it's like a ticking time bomb, or the whole thing of if you can turn a lump of coal to a diamond when you're puckered up with one of these, because they'll get real sick real fast. That's another QR code to some of the management of discussion about carotid blowouts. So what do you do? Same thing, man. You're on the stopwatch. You don't have much time. So you have to push direct pressure. And I mean, even to the point of where you're compressing their airway, you are literally almost going to have to choke them out to do this. And you got to get their airway. There's usually going to be enough blood and things like that you're going to probably have to secure their airway. As you can imagine, somebody with head and neck cancer that's had a radical neck dissection, this isn't going to be the easiest airway either. So number one, there's spurting blood everywhere. Number two, it's an airway nightmare. So this isn't easy. You also need to have good suction. And this is one of those, I don't know if any of you have seen the Decanto catheters. They are bigger, larger bore catheters. And I would consider looking at one of those when you're needing to do some large volume suction. Sometimes the Yonker or some of the smaller catheters that we use just aren't enough to get it done and get you a clear pathway. You need to get blood products going. I mean, the minute you see that, because they're going to be bleeding out right in front of you. And then, you've got one shot on destination facility. Honestly, if this is one of those where, again, a smaller hospital with less capacity, there's not a lot they're going to be able to do for them. Their only hope is to get up to an OR with a vascular surgeon ASAP. The other thing, when I say direct pressure, when I talked about pressure points earlier, if you feel to the top of your sternum, there's kind of a little divot, and that's called the sternal notch. Sometimes if you put a little pressure up there, you can stop some bleeding in that area. I shouldn't say stop, slow it down enough too. So while somebody's holding direct pressure, somebody else can hold some pressure at the sternal notch. I mean, it's sometimes it's like throwing a deck chair off the Titanic. It's not going to make a difference, but it's worth a try when you're pulling out all the stops to slow the bleeding however you can. So when I talk about this, number one, I've talked about bleeding in general. I've talked about some of the scarier kinds of bleeding, triple A's, thoracic dissections, carotid blowouts, your dialysis access. The one thing I think is a lot of the fundamentals for management are all the same. And so the big thing is to practice these things, to say, okay, what would we do if we got these scenarios? Is our tourniquet ready? Where would we go if if we're covering this part of the county, and one of these hits us, what's our game plan? A lot of these are so serious that they may bleed out before you can get there, even with a good response time. So I would say, especially in someone who has these conditions, somebody who has head and neck cancer, somebody who has a known AAA they've been following. Families need to be educated on what to do if they have warning signs or actually active bleeding and things like that. Sometimes a layperson response is their only chance of success. You need to have these discussions with your destination facilities to understand what capacity is and what kind of patients they can take and what kind of patients they can't take. And then you need to QA these cases every single time. You will learn something every single time you have these. And these are some of these what we call halo cases, high acuity, low occurrence. You may see these, 2 or 3 times in a career, if at all. And so, this is ones that you should be sharing with your entire services, QAing them so everyone's learning from these cases every time. Stop the bleed when I talk about community education. I'm a big advocate of Stop the Bleed. I'm sure you've probably done some of the classes locally in your area. And I'm a big fan of, we have Stop the Bleed. Well, we call them community aid stations all over our county, which is an AED, a Stop the Bleed kit, and Narcan all in a self-contained box. We have them in our bars. I have one in a bar called Sweat Hogs. I have them in some of our convenience stores, and then we have some standalone boxes that are climate controlled with a code that 911 can give out, so that if I'm in the middle of a rural part of our county, I can still in 5 minutes or so get over to a Stop the Bleed kit to bring to a scene if I need it. And I think that's a big deal. The sooner, time is of the essence always in these scenarios. Last before we stop, I think we're about the hour mark. Shameless plug, the first Wednesday of the month, we always do a state in-service. I know some of you get on there. Really want to keep building that. We start off with 5 to 10 minutes of housekeeping where we talk about different things that are going on at the state level. We do Provider of the Month nominations, so please send those to me. Even whether you plan on being on in-service or not, I want to recognize people for their good work. It does not have to be some kind of hero save. It can be just, hey, this guy or girl's a good person and always helping people around the station, whatever that looks like. And then we usually spend about 45 minutes talking about a topic and then finish up with some Q&A at the end. And there's a QR code that we put out there that automatically puts it into a cadence for you. So if you jump on there every month, that's a nice, easy way to, number one, feel connected with the rest of the state, and number two, get some easy CEUs. So with very few exceptions, it's always the first Wednesday at noon Eastern. So if you're interested, shoot me an email and I can get you signed up on a reminder list so that you know it's coming too. Mention those track meetings. There's North, Central, and South tracks. Those meetings are old. I need to update those. The next meetings will be coming up, I believe, in February. So I'll make sure to get those out. I think most of your service area is in that central track, but probably some of it gets down in the south. I don't know over in the west central part, where that divider line is, but those are good meetings, and I'd certainly make sure to hit them. What's that, Barry?
Or Central.
Central, yeah, I thought you probably were. But yeah, that's a good one to get on. Number one, it's a good meeting anyway. But number two, if you have some trauma-based initiatives, it's a good opportunity to get some funding. That's it. Any questions? And I think my next slide has my contact info. So yeah, feel free. That's eyazel@dhs.in.gov, and that's my cell phone number. Hit me up anytime. Shoot me an email if you want to get added to the in-service list, or if you, I like to get out in the state. And I apologize. I normally would have been there in person today, but they stuck me onto the schedule. This old man doesn't do as many night shifts anymore, and they slid one in on me. So usually I try to be there in person, so I apologize, but love to come out to your stations, get to know you, talk EMS, anything. So reach out anytime, and I appreciate everybody, and I'll quit flapping my jaws and be open for questions.
Anybody have any questions? Doesn't look like so. Appreciate it, sir.
All right. Thank you, guys. I appreciate everybody. Have a good day.
Thanks. Hey, guys, that was good. We're gonna go. Brooke, you ready? We're gonna get into our reports. Brooke's gonna do our STEMI report.
Good morning. Okay, so we're gonna do some STEMI case presentations. First case we have was a 55-year-old female. Transcare was called out for some chest pain. She reported that it radiated to her back and her neck. She was a smoker and was currently undergoing outpatient treatment with plans for follow-up on some chest pain and cardiology. On the scene, the 12 lean wasn't necessarily a clear presentation of a STEMI. Some abnormalities noted. So they called it in for chest pain with some of those ST changes. They did give the aspirin and nitrile as well prior to arrival. EKG was performed at Terre Haute ER and confirmed the STEMI. They did do the heart cath, and she had 100% thrombotic occlusion of the right coronary artery, and an 80% left circumflex. She recovered in the ICU and discharged the following day with plans to intervene. The culprit lesion was the RCA in that case, so they're going to do an outpatient intervention to that left circumflex at a later time. Here are your call times. Everything's super great, fantastic. First medical contact to the balloon was just outside that 90-minute goal, but I think it was due to that unclear presentation. Door to balloon for Terre Haute was 79 minutes. There is the EMS EKG. EKG when she got here. Path films, you can see that right coronary is not doing its job there. So once it was intervened, nice radiographic 0% residual stenosis. Treatment and course, obviously with unclear presentation, they called it in on the IHERN with ST changes. The prompt EKG and notification by EMS definitely expedited care. We were outside the 90-minute goal time for the first medical contact to reperfusion. Door to balloon was under the 90 minutes for this one. Good job. Our second case, anybody have any questions on that? So our second case, Terre Haute Fire was called out for a 65-year-old male, dyspnea, shortness of breath. He was found to be lethargic, had some rails and difficulty breathing. They gave him a duoneb, got him into the ambulance, placed him on a CPAP. They did do a 12 lead, which was concerning for an inferior STEMI. Patient began vomiting. They had to take the CPAP off. Of course, at that point, heart rate and SATs dropped. So they did a bag mask ventilation and got him over to the ED here pretty quickly. They did call the IHERN report, tried to intubate, ended up placing an eye gel. Once they got here, pulses were weak, around of CPR, got intubated, and then they did the subsequent EKG. So that did show the STEMI. Cardiology was consulted and the cath lab was activated. Once all of this was done, the patient happened to mention, hey, we know he needs cabbage. That take very good care of himself. Shocker. Could have been some good, helpful information, but would have changed what we had to do. So did go to the cath lab, had obviously severe coronary artery disease to all the vessels. Surprisingly, his EF was 45%, which is shocking as much disease. So they did place a balloon pump and took him to the ICU. He was a pretty high risk case, so there wasn't much they could do for him here. Once he got extubated, they had consulted cardiovascular surgery here, but it was recommended that he get transferred out. So once he was stabilized and extubated, they did send him to St. Vincent Heart Center. Unfortunately, there they also told him the same thing, high risk. But they did do some medical treatment there, change some medications. His EF recovered to approximately 60%, which is pretty remarkable. Still not a candidate for cabbage, so he's following closely there in Indy with them for full-driven medical care. There's your call times. Again, excellent. You guys do a really nice job getting people where they need to be. First EKG once he arrived here. And then cath images, you can see that right coronary and then all the other ones. I mean, it's just diffuse. You could see blockages. So had poor targets. There really wasn't a good candidate for surgery. So condition of the home resulted in some extended time on the scene. Unfortunately, those are things that we can't control. Once he was secured in the ambulance, he was expedited care transport here. CPR intubation is required before going to the cath lab. So these are all unavoidable non-system delays. He did receive prompt care despite all of these things that, gotten our way. So really nice job, everybody. Thank you so much. Dedication to the community, we appreciate
Thanks, bro. Do
Thank
I have any questions for her? Beth? Beth Harrison, stroke coordinator, is going to do our stroke presentation. Beth, I'll put the arrows. We'll push another button. So you never know.
I'll mention that's at the start.
Yeah, you-
Good morning, everyone. Our first case is from our Clinton Hospital. Here. This was a 58-year-old female. She was independent. Our prior medical history includes smoking and hyperlipidemia. She had a few medications, mostly around blood pressure and some not blood anxiety. She had just lost her husband and was dealing with that. EMS was dispatched to a private residence for unknown medical. She was found lying on the ground crying. She was alert and oriented ×3, but had slurred speech, some aphasia, right facial droop, and right-sided weakness. She had called her daughter about 9 o'clock that morning and was fine. And she later called about 11 o'clock with slurred speech. She was upstairs. She was moved down with a stair chair and transferred to a cot. Her EKG showed sinus. Her coma scale was 15. Blood sugar was good at 98. 20 gauge to her left AC was started. Vitals were okay. Room air was okay. The Cincinnati pre-hospital score was positive. Positive, and a stroke alert was called via IHER to the Clinton ER. Here's our EMS response times. She must have lived fairly close to the EMS office. Her find 11:26, en route at 27, on scene at 28, and outpatient at 29. Like neighbor across the street. They departed the scene at 11:41, arrived at the ER at 44, and she was referred here at 48. In the emergency room, she went directly from CT to CT per EMS cart. Her last known well was established at 9 o'clock, but she did call her daughter at 11:08, so they were kind of a little bit lenient with that last known well. Her NIH was done at that time, and it was 12, so she was having a pretty good sized stroke. Her CT stroke was done 11:49, and it was negative for a bleed. Our teleneuro consult was consult, and they advised T&K, and it was given at 12. We had a door to needle time of 33 minutes, so just a little over our goal of 30, but really good time. But I did. Her CTA was completed at 12:37, and it showed a total of occlusion of her left internal carotid artery. She was transferred to IU at 13:15 by a lifeline for a thrombectomy. And I'm really not sure what happened to her. She doesn't come back in our system. So not really sure what happened at IU, but maybe one day we'll find out. The strength stop in this case, they're really good. Cincinnati pre-hospital stroke scale was completed, the vein was completed, stroke alert was called, our protocols were followed, and she did go directly from CT to CT from the cart, which is our best practice. So we did a really good job on this. Other one's not on here.
I just copied everything you gave.
And I sent you two. I said the union case, but that's all. We'll just do it next time.
Okay. Yeah, let's say it. Sorry about that.
Okay.
I think it's
Just in the same
two-
email.
It's two separate. I thought I got it twice. Okay. Tina, you ready?
Yeah.
Okay. Sorry about that, Beth. We'll just use the next one. Next one.
Lori, we just have two quick ones. Right, this first one was 60 people and fell from ladder. 911 call came at 17:25. They were dispatched 17:25, en route 17:26. On scene 17:50. Depart at 18:13 and at Union ER at 19:12. It seems like they were out by Raccoon Lake. That's why it took so long. Time zero dispatch, call dispatch 0. Dispatched en route was 1 minute, en route to arrival 24, on scene to departure 23, departure 10, 9 minutes. And the total call from 911 to arrival was 1 hour, 47 minutes. So, EMS report said they were dispatched with the volunteer fire department for, fall off a ladder about 8 feet. He was on blood thinners. On arrival, they found him lying supine. He was getting onto the roof of his lake home. There's some leaves off the roof and, roof looked slick. He woke up on the ground with his wife next to him. That's all I remembered. His wife said that he lost consciousness for about 10 seconds and he was normal when he came to. Fire department was holding C-spine. They cleared it. But they, because of the fall off the ladder, they applied a C color. He had a laceration to the left side of his head, 3 to 4 inches, bleeding, controlled with pressure. Hematoma on the posterior forearm. Breath sounds were clear and equal. Complained of thoracic pain, back and left shoulder pain, chest soreness. Said he felt like he hit his head. They placed him on a backboard and got him onto the cot, rolled him, took out the backboard, put him on the monitor, gave him fentanyl and Zofran. Said he was having pain with deep breaths. GCS was 15. Vitals were pretty good, 132/83, 79. Sat was 80 on, or 90 on room air. Blood sugar 107. Pain was 8, and the entitled CO2 must have been normal. Fentanyl was repeated. He was still having some pain. They put him on up to 2 liters because of second dose fentanyl. Called an IHERN to Union ER and transported him. So the pre-arrival said he fell 7 to 8 feet off of the ladder. Negative blood thinner, they said, head lag and positive loss of consciousness. So that's our criteria. So he met the fall for high risk over 65 because he was on thinners. So on arrival, he was a level 2 activation. Doctor's note said he had a past history of vasovagal syndrome, fell off a ladder, was having chest pain, was breathing, said he hadn't walked since the incident, said he felt like he had a cut on his left arm. So he was alert and oriented. GCS was still 15. Vital signs were still pretty good. 87, also 87, rest 17, 120/66, 94% on room air. Chest x-ray, arm x-ray, the CT of the head, spine, and CT of the chest, abdomen, and pelvis were done. Labs were done, CBC, PTC, alcohol. Trauma consulted in the ER. I said his chest was top 80, operation was shallow. Hematoma to the left dorsal forearm, 5 centimeter laceration to the posterior scalp with an underlying hematoma. They stapled his scalp back, gave him IV antibiotics and some morphine. White count was 16.9, drug and alcohol was negative. CT in the of the head and C-spine were negative. Radius and ulnar x-ray was negative. CT of the chest, abdomen, and pelvis showed acute fractures involving the left 4th through 11th ribs posteriorly. Displaced fractures involving the anterior wall. The T8 vertebral body. Acute fractures involving the left transverse L2 through L4. So diagnosis: accidental fall from the ladder. Fractures at the left 4th through 11th ribs. Closed fracture T8. Fracture of the spinous process, lumbar vertebrae, laceration of the scalp. So trauma recommended immediate transport to a level 1 center, and he went to St. Vincent via LSA. So these, I'm not real good at finding the pictures on the CAT scan, but I went to radiology and Dee helped me. So on that first x-ray, you can kind of see where there's that widening. The first widening, like right up here. She said that was from, he squished it. So when he fell off the roof, I don't know if he just fell down, like down and then fell. And then underneath that one, this little line right here is also a fracture. I would have never seen that. This looks like you to me. And then the second and third fractures or films are, you see these are ribs. There's a fracture, pretty good fracture here. There was a fracture there. And there's a line here. I didn't get all of them, but that's decent fractures, I guess. So he went to St. Vincent, or I think it was St. Anybody have any questions on that one? I think everybody did everything. Unfortunately, we don't get a lot of feedback from hospitals up in Indy, so I don't know how I did. Okay, so the second one was a 13-year-old male. Oh my God. He was not a fall from a ladder. Barry is supposed to check these for me. Yes, I will throw you under the bus.
Sure, I didn't know the 13-year-old didn't fall from the ladder, so.
No, he did not fall from a ladder.
I'm gathering.
Yeah, he was an ATV accident. Sorry about that. 911 call, 1729, dispatch 1729, en route 1730. They were on the scene at 1735, departed at 1748, and at Union ER 1805. Patch was 0, dispatch en route was 1 minute, en route to arrival was 5. On the scene to departure was 3 minutes. Depart to arrival at ER was 13 seconds. So the call time was 40 minutes. All right, so there we go. Dispatch took gravel road for a 13-year-old male who fell off his dirt bike going 20 to 30 miles an hour. They said dirt bike, but I think they meant ATV. So the ATV rolled a couple times, did not wear a helmet or any protective gear. On arrival, volunteer fire department again was on the scene. They applied a C-collar. Complaint of neck pain, he was in some distress. Somehow he got into the back of a pickup truck. I don't know if somebody picked him up, put him in there, if he got up there. It didn't say. Abrasions along the right chest wall. Complaint of chest pain, making it difficult to breathe. Breath sounds were clear and equal. His stomach was soft and non-tender. DCS was 15, blood pressure 144/98, heart rate 124, sat, breaths were 26, sat was 97% of room air. They gave him IV fentanyl with relief of pain. Started some normal saline, put him on the monitor, called IHER and took him to Union ER. Pre-arrival said ATV rolled 20, 30 miles an hour, abrasion, shortness of breath, neck pain. Trauma activation was a level 2 on arrival. He was a 13-year-old male in ATV accident, wasn't helmeted. Vehicle rolled over multiple times. Patient fell to the ground. He had bruising and tenderness to the right clavicle and right chest wall. Alert and oriented, GCS was still 15. Heart rate is 94, rest 16, blood pressure is 121/98, as that was 100% on room air. So he was stable throughout the state. Mild distress, he had bruising, right chest wall, right upper abdomen, and with tenderness. They did labs and a type and screen, gave him fentanyl twice, saline bolus. He met level 2 trauma for the high rate of speed, high energy dissipation, rapid deceleration. The bike count, when it came back, was 19.1. Alcohol was negative. Platelets were 399. His phos was up a little bit. Alk phos was 183. ALT was 424. AST was 521. Hemoglobin was 12. And then 9. CT of the head and C spine was negative. X-ray of the pelvis was negative. Right clavicle was negative. CT of the chest abdomen, so pulmonary contusion changes noted in the right upper and lower lobes. Trace left-sided pneumothorax. High-grade liver lac was surrounding mild to moderate hemorrhage, and there was also some hemorrhage in the pelvis. So they did speak with trauma, gave for them, and they said, yeah, go ahead and transfer him. So diagnosis was pulmonary contusions on the right with no rib fractures, liver function changes associated with the high-grade liver lac with active bleeding, and trace left side pneumothorax. So he did go to Riley by hair. And again, my friends in radiology helped me. Yes, I really didn't know what I was looking at here. So I guess this is, this white in this dark area is where it was bleeding. And then over here, you can see this faint little line here. And that's actually the laceration itself. And then there's another. And I think when they brought him in, they were focusing more on that. It seemed like the chest injuries. I don't know that anybody was expecting this. So it's, these two cases were just like, just because they kind of look okay, doesn't assume they're okay, and you know for sure they're okay. And then down here, this darkened area, this is also blood. So we have this and then the laceration that was up here and here. And my only wish for Christmas is that when radiology would read these or the doctors look at them and they would put a degree. Because they say a high, high grade lac, but that doesn't, for our purposes, we need to know, like when we're putting it in the registry and stuff. And I think it's a little more descriptive if you know if it's a grade 3, grade 4, grade 5. So that's all I want for Christmas. And but anyhow, he went to Riley, and you know that he has been his doctor. I got anything?
I think both of those cases are very good examples of they're stable until they're not. Because we had an older adult and we had the kid. Fun fact, there's a law in the state of Indiana, even on private property, if they are under the age of 16, they're supposed to have a helmet on any UTV, ATV, side-by-side, any of them. It's called Kate's Law, and it was a side-by-side wreck that killed a little girl, very similar to that crash. But both of those are very good examples of why really good narratives from you guys and really good reports from you guys. And I know we're on the struggle bus here for the 60 seconds of silence, but you're supposed to be given, that's Miranda's project right now, you're supposed to be given 60 seconds of silence because it gives you the opportunity to give one story to every person involved in care one time and everybody gets the facts. And so I need you guys to kind of be a little bold. And I know some of you are kind of new to this game, but I need you to stand up and say, hey, I would like my 60 seconds. It's not going to take you a whole minute to give your report. We know that, but we call it 60 seconds of silence. It is crucial to the care of these because you guys see this stuff. You guys know these patients inside out, especially like Park County. They spent 40 minutes transport. It wasn't their fault. They came from Raccoon Lake, but they knew that story. And I kind of laughed because she was like, in both of those cases, it's like a reverse fish story because the story gets diluted every little bit. Every time it gets told, it gets diluted a little bit. Because first the guy fell from an 8-foot plus ladder. Then he fell from a 7 to 8 foot ladder. And then if you look at the chart, it was like 6 to 8 feet. And so and maybe it was, I don't know. I wasn't there, but maybe they did get a little exaggerated. But either way, if they give you those 60 seconds, we get the whole story and all of us get the same story. So those are just really good examples of how they're stable until they're not, especially kids. I don't know, you probably heard it. Kids are stable until they're not, right? They compensate, crash, even 13-year-olds. So good job. They were both very good jobs, but it's just really good examples, I think.
Thanks, Jack. Anybody else have any other questions or anything? Couple things I want to reiterate. QR code here to sign in, and then you could get credit for it if you didn't sign in on the thing. But if you did sign in, don't worry about this. You can do both. It doesn't make a difference to me. For those of you online, this is where you can go. You fill out your name and your PSID number, and I'll give you credit for being on auto review. Again, don't forget that everything's changing Saturday morning at 12:01. Those cases that I mentioned are critical. These trauma cases like this need to come here. I mean, the trauma surgeons are here, so make sure that any OB, pediatrics, anything like that needs to come here. Okay. If you have questions, call medical control. Ask them. If they need to be asked. The whole idea we're trying to keep from having to transfer people from one facility to the other as few times as we need. Okay. So, anybody have any questions for me? Those of you came, thank you very much. Appreciate you being here.
The other thing I want.
Me too.
Yes.
Oh, I already got my energy drink before I came.
2 of them. I'm still gonna get your coffee.
It's locked.
Got my energy drink and I still need
7
coffee.
brew. Would have been there.
Yeah.
We usually get to like, no problem.
Anything.
Do I?
Yes,
Yeah, yeah, ours aren't super pretty.
I mean, I'm saying, no, they're.
Yeah.
You go.
The badge box right here.
How far did we get? Did we get through the first slideshow?
You have to look in the.
Thank you. I still have mine.
That CDC algorithm follows, because if you look at it, it doesn't tell you every patient has to. And there are medics that are gonna tell you that, and that's not. It says, eat and go to college. He's bad.
That's something special.
And then I go nowhere. Send me. Yeah, it smells like Terre Haute City.
Juice.
But I was gonna say something. That's right now. Are we doing? That's it. Are you the one that brought the? That was so long. You're right.
He'll be lucky.
I think he was there for. Listen, don't be trying to trick me. He gave her. Yeah, we were watching you guys. I was like, I don't know if you have problems with my answer. We forget it or calm down. Yeah. But like. Oh, that's. Haven't they seen Full House? Well, like.
I have this thing, I don't have a fever.
Can't do this. I'm like, come live with me. That's what you.
I can't say, it's like I'm having a.
I got a room for you.
That's how it was.
And if I don't, I'll build one.
You can use that, or it's right there.
Right, a lot, yeah. Oh, I know. I thought I was talking to that. What?
We got so much we gotta go.
I parked on the other side.
Like
But
something
yeah.
like through before. You know, I would rather not have to take four tabs than one day.
Good night.
Oh, that's part.
I hope because it was slow. At one point, we sat there for like 3 hours, like I dozed off. We're like, and it was hilarious because Haley was like, "Looks like someone didn't get enough sleep." I'm like, yeah, like I did. I just got a migraine. She's like, "You're awake?" Yeah, we were snoring. So they're trying to rein, second assessment chapter. She was like, oh, you don't gotta tell me, I'm like, come on, get it.
Understand, like, that I have, I'm like, oh, I should do that, and they're like, I run into that a lot.